I read stuff.
Yeah.
Hey guys, I think we might make a start. Thank you all for coming. The way we'll go by this is pretty much similar to last time. We'll go through 4 lectures today and 5 tomorrow. We'll be breaking for lunch about at 12. We have Subway today and Krispy Kreme and banh mi tomorrow. So do stay tuned for that. We're starting with epidemiology, which is much more important than you guys might think, because we have about 15% of the VIA just being on epi, which is really important because I'm here to learn all of my stuff. So please pay attention. Yeah.
Cool. Hi everyone, I'm Sarah, as you can read. I'm a second year here at Monash, and I'm giving you your epi lecture today. But yes, after this, I know epi's hard and doesn't always make a lot of sense when you're just hearing it for the first time or like once. So feel free to email me, that's my email, and feel free to ask me questions either during or after, like I'm really chill with it. Yeah, cool. Okay. Okay, so Karan already kind of talked about this, but in general, I actually think, okay, epi is really, really important. Because if you kind of think where you're heading, hopefully being a clinician in a couple years, not everything you're taught in med school will still be the exact same because we're always learning more things and trying to become better doctors. And because of that, there's lots of new research coming out, and you need to be able to interpret that research so you can make the best, like, clinically sound decisions based on evidence. So that's why I really like epi, because I think it's really important for not just now, but in the future. Yeah, okay. So more about today's lecture. It's going to be question-based. Sometimes I'll give you the information either before or after the question, depending on how difficult of a concept I think it is. But I'm going to need audience participation. I know it's 10 a.m. in the morning, but hopefully you guys will get more out of it that way rather than me just kind of talking at you. Yeah? Yeah. Cool, okay. First question, let's get started. It is necessary but not sufficient to be exposed to Mycobacterium tuberculosis to get TB. True or false? Hi, come on in. Okay, what do you guys think? True. Good job. Okay, so quick definition recap. Sufficient means that you need, this by itself will cause the disease. Necessary is that the disease will only happen once you have this thing. Like you have to have this thing in order for the disease to occur. I'll give you guys these slides after, so you don't have to take notes if you don't want to. Just so I can keep it moving, but yeah, cool. Okay, so now you've learned that. Which of these risk factors are either sufficient or necessary for lung cancer? Hi, yes. So, yeah, none of the above. Because you can have lung cancer without having any of these, and any of these by themselves do not automatically cause lung cancer. Yep? Does this kind of make sense? Yeah? Cool. Okay, so I put this stuff before the question on causation, just to quickly recap. So temporal relationship, you need to make sure that the cause precedes effect. Plausibility, you want it to be plausible based on what you already know. Consistency is that other studies show similar results. Strength of association is that more like numerical kind of based stuff. Dose response, if you have more of the exposure, do you get more effect? Reversibility, if you remove the cause, do you decrease the risk of effect? And study design is what evidence you're using to make your decision. Cool. So which one of these does this show? And a lot of these might be taken from your post-quiz or my post-quiz, so it might have changed, I don't know, but yeah. Cool, any ideas? Yeah, anyone have any clues? Just shout it out, because I just hear kind of general murmuring. Yeah, plausibility, great. So, okay. Cool, so with consistency, guys, Okay, cool. So with consistency, it's not really referencing any other studies. Strength of association, we don't have any numbers. And reversibility, it doesn't say that if we take away oral contraceptives that we don't get this stuff. Yeah. So plausibility is that it makes sense. Yeah. Okay. You don't actually have to calculate the numbers. I put all the like working out so that it's not about like just using a calculator. So yeah. So prevalence. How would you calculate prevalence? Where did that screen go? Oh, I don't know how to do it. It's cool. Don't worry about it. Oh, nice. Wait.
Okay.
Yeah.
Oh, I took away your view.
Yeah, that's fine. Okay. Cool, you guys are given a bit of time for that one, even though the screen was off for half the time. So what do you guys think it is? Yeah, nice. So prevalence is just a count of how many people have it, irrespective of when they got it and all that stuff. Yeah, it's just who has it. Okay, so this is a bit more complicated. So yes, so I'll give you guys a bit of time and then I'll talk through it a bit more. Cool. Anyone starting to have any ideas? Okay, we're going to do both. So who thinks it's A? You can raise your hand. Who thinks it's B? Who thinks it's C? Who thinks it's D? Nice. Okay, most of you got that C. I'll just explain it a bit because it's a bit of a complicated question. So if you're looking at incidence, you're looking at new cases. So that's why you exclude the first 100 that already had high blood pressure. So now we're down to 1,900 women. 300 of those developed high blood pressure. So that's the new cases, 300. And now we need to estimate how many person years this was over. So we've got 300 women, if they developed it at the end of 5 years, only 5 years of their time contribute toward the overall person years. And then 2,000 minus 100 minus 300 is 16,000, and they're the ones who were disease-free for 10 years. Does that make sense? No, it doesn't make sense. Okay, cool. I'll explain it again. Oh, hi, sorry. It's not specific a formula. It's more that you're calculating over how many person years was experienced, how many had the disease. Yeah. So 300 had the disease. Guys, cool. So, okay, I'll go over it again. All right, so first things first, how many new cases were there? 300? Yeah, so that's the top bit. That's the new cases that we had. So the bottom bit is looking at how many person years that were experienced, like how many cases occurred over a certain amount of person years. So we don't count the ones that were already diagnosed before the 10 years even started, right? So we've got 2,000 women, 100 already don't count because they already have the disease. So now we have to look at the 300 women who developed high blood pressure. So they developed it at the end of 5 years. So after they develop it, it no longer counts towards the total person years because they do not have any chance of getting the disease because they've already got it. Yeah, so that's why it's 300 times 5, because at the end of the 5 years, there's no more chance of them getting the disease. Whereas after that, so you've minus the 300 who just got it and the 100 who already had it before, you're left with 1,600. And for all those 10 years, they were at risk. Does that make more sense? Yeah. If you have more questions about it, feel free to ask me afterwards, but I might need to move on. Yeah. So I put this in deliberately because incidence questions tend to be a bit more harder than prevalence questions. An important thing is to know how to calculate both in different methods. Okay, so prevalence rates can be assessed by which of the following questions? Because they've recorded the 10 years after, 10 years later, all 2,000 women conducted it. So it's like the 10 years after we're measuring the incidence rate time in. Yeah, out of the 2,000 people in the study, yeah. Okay, so which one of these can assess prevalence rates? Anyone have any ideas? So since prevalence is having the disease at any time, it's all the above. Cool, is this incidence or prevalence? All right, hands up for incidence. Hands up for prevalence. It's actually incidence because cholera is an acute condition. Yeah, yeah. Cool. Okay, so I'm not going to talk through this table because it's long and complicated, but this is basically the number who develop the disease over a number of person years at risk of getting disease. That's what we just did. But you can look at this in your own time. It's actually from your, yeah. Cool. And you don't really need to know these bottom three, but it's mainly the top three, yeah. Okay, relative risk. Calculate the relative risk of the disease between those exposed and unexposed to pesticides. Oh, sorry. Yeah.
Question, 2 questions ago, which was saying that prevalence is over any time.
So for example, it's like a particular point in time being like, at this moment now I'm going to measure prevalence in this room. So before, if they've ever had the disease, then, are you talking about the question one, this one?
Yeah, if the prevalence is just a particular point in time, wouldn't it have to be C as opposed to high blood pressure against C?
That's a good point. Let me think. Do you have high blood pressure in your lifetime? It depends, because it kind of, high blood pressure is like a chronic condition. So I think it makes the assumption that if you've ever had it before, you currently have it now. Yeah, I think that's the assumption it's making because of the disease. But you do have a fair point, that if it was like an acute condition and you're measuring prevalence, you wouldn't be like, did you have cholera 20 years ago and still count it today? Does that make sense? Yeah. Okay. Oops. Okay. So what do you guys think about this one? Relative risk. A, B, C, or D? Okay, let's take it to a vote. A? Okay, B, C, and D. Okay, so it is B. So relative risk is comparing the risk in the exposed and the risk in the unexposed. So if we think of that in mind and we go back to here, so what is the risk in the exposed? So those exposed is 40 divided by 2,500, whereas comparing the risk in the unexposed. So 60 divided by 7,500, yeah. And so that's how relative risk is calculated. It's comparing, you know, if you have the exposure versus if you don't, how likely are you to have the disease? Does that make sense? Yeah? Okay, cool. So there's a couple different risk calculations, and And so attributable risk is also really important, because if you take away kind of like the risk in the unexposed, or like the background risk that almost everyone experiences, it's much better look at how much the exposure is actually affecting your result. Attributable fraction. So this is just basically out of the exposure risk, how much as a percentage wise can be attributed to the specific exposure rather than just all the background stuff. And population attributable risk is looking at the risk in the total population minus the risk in the unexposed, and then you can do that as a percentage as well. Yeah. So yeah, like I said earlier, you guys will get these slides. I just didn't put them up because I have all the answers at the moment. Yeah, cool. Okay, the attributable fraction. So that is this one. So risk in the exposed minus risk in unexposed, and then as like a percentage. Yeah, cool. Okay, I'm gonna go back. Risk in exposed minus risk in unexposed divided by risk in exposed to be like, to make it a fraction. Fraction, percentage, or fraction. Anyway, all right, let's take it to the vote. Who thinks it's A? Nice! Oh, I'm so proud of you guys. Okay. Yeah, this took me a while. Okay, I'm not gonna go with the other options because it's pretty clear. But yeah, I guess try not to think about it as memorizing all these formulas, but kind of trying to understand like, okay, how much risk can you actually attribute to the exposure? And that's kind of what I want to get across. Yeah, hey, great. Okay, so I'll go back and show you the thing. So percentage of a disease in the whole population. So this one is you take away the risk in the unexposed from the total population, and then you find the risk as a percentage of that. Yeah. Cool. So what do you guys think? Oh, I'll give you more thinking time. Yeah. Okay. We're feeling ready? Yeah? Yeah? Okay. Who thinks it's A? Who thinks it's B? Who thinks it's C? Who thinks it's D? Nice! You guys are doing great! Oh my gosh. Okay. So, calculating risk odds ratio. So, some people like the, oh, for the last one, it was B. Yeah. So, the risk in the total population is 100 divided by 10,000, minus the risk in the unexposed, which is 60 divided by 7,500. And this is then calculated, divided by the total risk in the population. Yeah. Okay, so some people like the A, B, C, D thing, but then you have to worry about like changing the table and all that stuff. And I don't really like that because I don't like memorizing things, but I don't know why I'm doing med. So I'm kidding guys, it's great. So basically odds ratio is odds of a case being exposed versus odds of a control being exposed. I'm gonna say that again. So odds of a case, there's someone who has the disease, what is the likelihood that they were exposed? Compared to a control, someone who does not have the disease, what is the likelihood they were exposed? Does that make sense? Okay. Oh, okay, so this is just like a bit of clinical relevance. So this is like something from ICL, but you know how you have like all the risk factors and you do this for like a bunch of conditions? So this is for deep vein thrombosis, if you guys know what that is. I think you do, I don't really know. So basically, a lot of people talk about immobilization and family history and stuff like that, but if you look at the odds ratios, it's not actually as significant a risk factor as all these other ones at the top. But if you are trying to be a good clinician and you look for all the weak clinical risk factors, you may miss some really big ones because you're not focusing on the right stuff. So anyway, that's how odd ratios comes into things. Yeah, okay, small side note. Okay, calculating odds ratios. So odds that a case was exposed divided by odds that a control was exposed, where cases are those who develop the disease and controls are those who do not. Okay, cool. So I'm going to start going through it. Yeah. So A, B, C, D. Okay, so a lot of you didn't put up your hands, so I'm going to explain the answer. So odds that a case were exposed is 40 on 60. So these are all the cases developed disease. So it's 40 to 60 on how many developed the disease, or yeah, so how many of the case were exposed. And then the second part is how likely a control was exposed, which is 2,460 to 7,440. Hi. Oh man, I can't do maths. That's great. Yeah, sorry. Yeah, both are correct. But yeah, so either way, if you work it out, that's fine. But that's kind of if you go based on the kind of theory. Yeah. I'll fix that in my slides. Thank you so much. Okay, cool. Does that make sense to everyone? Yeah. Sorry, I can't hear you. Yeah, okay, guys. So I just got a question on why it's not 40 on 100. So we're looking at, so 40 on 100, okay. So when we're looking at odds, we're comparing specifically the two groups rather than overall, if that makes sense. So if you think about when we went back to relative risk, that was kind of more that calculation. Yeah. The relative risk refers to that, whereas odds is amongst this. There's a ratio of 2 to 3 of being exposed. Yeah. Yeah. Okay, cool. All right, so confounding. Which of these cannot be used to control for confounding? Okay, hands up for randomization of sample. What about double blinding? Matching of cases and controls in a case control study, and placebo. Yeah, so it's actually double blinding and placebo. So if you think about confounding, confounding is another factor that affects your results that you didn't really measure or account for. So if you blind everyone, that still doesn't change the fact that it's going to confound the result. As in like, so do you remember that example of how people who drink more coffee have like heart disease or something like that, but then they're also smokers? Yeah. So if you double blind everyone, it still doesn't change the fact that they're smoking and that affects the results. And placebo, if you give them a placebo in a drug trial, it doesn't change the fact that that other thing is still happening. Does that make sense? Yeah. So I would like, if you guys are feeling a little bit overwhelmed by FE, I understand. It took me a long time to work through it, but I'm trying to give you all the hardest questions possible so you can ask me about them rather than just calculate the prevalence or something like that. Yeah, because that's something you can do in your own time. Yeah, okay, cool. All right, so confounding, these are different things you can do to account for it. Yeah, so if you match it, for example, then if they're the same, then the only thing you're changing is your experimental value, experimental like condition you're giving them, and so that's why it can help control for confounding. Yeah, so these are all the stuff. I won't go through it in too much detail, just because I want to keep moving. Yeah. Oh, okay. Everyone's favorite part: specificity and sensitivity. Cool. So I'll do a quick recap. How do I get rid of this? Oh, okay. Cool. So negative predictor value, if they get a negative result, what is the probability they're actually negative? Positive predictor value, if they get a positive result, what's the chance that they actually have the disease? Specificity. Okay, so with specificity and sensitivity, specificity is how good are you picking up true negatives as negatives? Yeah. And sensitivity is how good you are at picking up disease individuals as positive. Yeah. So with these, we're going to go into a longer question on it. So I want you to keep these in mind, but I'll keep repeating them whilst you guys do the question. Cool. Okay. Maybe this will go. Okay. So just to clarify, clinical exam is like the truth, and diagnostic test is the one with checking the specificity and sensitivity and positive predictor value and negative predictor value on. Okay. So which of these values are not correct? So you need to work through all of them. Yeah. So positive predictor value is that how likely are you to actually have the disease if you got a positive result? Sensitivity is how good you are at picking up true positives out of all the positives. Specificity is how good are you at picking up the true negatives out of all the negatives. And negative predictor value is if you get a negative result, how likely is it that you don't actually have the disease? Okay, I'm going to go through the question now. Hopefully you guys are ready. If not, okay. I'll just give you guys another minute. Okay, cool. I'm going to go through it now. Ooh, oops. Okay, cool. Okay, cool. So this is a pretty confusing area, so I'm just going to go through it really slowly. So negative predictor value is true negatives divided by total negatives. So that's 80 on 100. So that's correct. So positive predictor value, true positives divided by total positives. So that's 60 divided by 100. So that's not correct. I'm going to keep going through the other ones just to make it really clear. Is that making sense so far? Am I going too fast? Yeah?
So when you talk about total positive and the positive predictor value, is that talking about the total positive in the diagnostic terms or total positives that actually happen?
So here, like these ones?
Yeah, so like this one, the total positive, not total positive that come out.
Yeah, because it's out of the positives, how likely are you to actually have the disease? Yeah. I'll amend that later. Thank you. Okay, cool. So specificity is how good it is at picking up true negatives out of total negatives, so that's 80 divided by 120. And then sensitivity is how good it's picking up true positive out of all the positives, so that's 60 out of 80. So positive predictor value is wrong, because that would be on, if you get a yes on the test, how likely are you to actually have the disease is 60 out of 100. Yeah. Cool. If you have questions about that, feel free to ask me later, but I might just keep moving on and you'll have the next thing. Okay. Diagnostic versus screening. I'm not really going to ask you a question on this because if you read it, it's pretty straightforward, all of the questions they ask. It's more just like, if you do a diagnostic test, you're trying to confirm a diagnosis where you already have some information, where a screening test is in the general population when you don't have any idea whether they have a condition or not. So screening, so there's different kinds of screening. Opportunistic is often what's done at like GP clinics. Patient comes in, they happen to fit the description for some screening, then you would screen them. Mass screening is just everyone can be screened and there's no real differentiation between like who is likely to have it or not. High risk or selective is that you, at risk populations, you're more likely to screen. And multiphasic is just like you do it in multiple different like times and stuff like that, and different tests, and like it's a bit more complicated, but you don't really need to know about it. It's more just like differentiating which screening, if they give you an example. That's most likely the question they'll ask on something like this. Or whether a test is diagnostic or screening. Yeah. Cool. Okay. So these are two kinds of biases. Yeah, I don't know what the plural bias is. So length time is that you are more likely to pick up diseases that are already slow, because if they're present in a patient for an extended period of time, you have a high probability of picking it up. So the length time bias is that you are picking up slow cases of disease, just because since they're slower, they have longer time to be picked up. Yeah. Lead time bias is that if you pick up someone has a disease earlier, that's great, but maybe your treatment doesn't actually help them. And because it doesn't actually help them, it still looks like they survive longer, but that's just because you picked it up earlier. Yeah. So that's length time versus lead time. Yeah. And so the lead time is that you get that extra time before they usually present, but it's actually kind of futile because you're not fixing anything, but it just looks like you are because you picked it up earlier. Yeah. Cool. Oh, okay. So instead of telling you all about like what study designs are and like just listing out all the features, we're going to do it as like a reverse question. So I'm going to give you a couple qualities of a particular study, and then I'm going to give you a couple options for which kind of study design it could be. Yeah, cool. Okay. So I use odd ratios. I'm typically used with rare cases, and I'm susceptible to recall bias. What study design am I? Just shout out the answer when you know. So, sorry. It's actually case control. So case control is the big one. Case control is the big one that is susceptible to recall bias, because you're asking about their exposure after they've either got the disease or they don't have the disease. Odds ratios, because we're comparing the odds ratio is odds that a case is exposed divided by odds that a control is exposed. And typically with rare cases, because you're looking for specific cases. Yeah. Cool. Next one. So this one's a bit of a giveaway, hopefully. Yeah. Experimental type of study design, uses placebo and double blinding, groups are randomly. Yeah, RCT. Cool, so it's RCT. So experimental type means that you control the exposure. And so that's when you can use placebo and double blinding, because you're controlling the exposure. Whereas in all the others you can't. And groups are randomly allocated usually. Yeah. Okay. Small sample size and no comparison group. for rare diseases, and it's used for hypothesis generation. It's technically 2 of them. Yeah. Yep, I'm hearing it float around. So case report and case series. So the difference between a case report and a case series is a case series is just a bunch of case reports on the same disease. Yeah, that's why I kind of group them together, because they fall into the same kind of pitfalls as well as the same strength. Yeah. Okay. Calculate prevalence, cannot infer causation. Outcome and cause are measured at the same point in time. Yeah, cross-section. So it calculates prevalence because you only have this one point in time where you can measure everything at once. So, so it doesn't have like a time period where you can calculate incidence over, because it's just this one section. You can't infer causation because you're measuring both the exposure and the outcome at the same time, because you're only getting this one slide. Yeah. Does that make sense? Yeah, cool, okay. So this is when you compare cases versus controls. It's forward in time, and it commonly loses participants to follow up. Any ideas? Okay, hands up for case control, hands up for cohort, hands up for cross-sectional, hands up for case report. Good, yeah, it's cohort. So cohort is the big one that is always forward in time, because you're following a group of people over time to see, you know, if they've had the exposure versus if they're control, and you can kind of see how their lives pan out. And commonly loses participants to follow up is a big deal, yeah. Okay, uses pre-existing data, hypothesis generating, groups of people. Okay, cool. So what do you guys think it is? Meta-analysis, case control, ecological, or RCT? Yep, so it's ecological. Ecological is big because it tends to like compare like whole groups of people, like countries and stuff like that, and it's for generating hypotheses. Okay, this is from, I think, one of your post quiz. I think. Yeah. I'll read it out to you. In an outcomes analysis of coronary bypass surgery, health services researchers identify charts of all patients diagnosed with 3 vessel disease at 3 major clinical centers during the past 10 years. These patients are separated into those who initially were treated surgically and those who were initially treated medically, with surgery used if medical treatment was unsuccessful. Aggregate results for mortality and a variety of other outcome variables were compiled for each group to produce prognostic profiles for those initially treated medically versus those who received immediate surgery. This study was a Okay, cool. Hands up for cross-sectional. Hands up for hospital-based case control study. Hands up for prospective cohort study. Hands up for retrospective cohort study. Yeah, so let me think. Retrospective cohort study. Okay, because it's the past 10 years. They're looking back, yeah. Okay. Pardon? Sorry. Oh, I can't hear you. Sorry, what was your question? this is kind of one of the options in the post-quiz. So a hospital-based, because you could have a case control study that is based in a hospital. I don't see why not. Yeah. I think they just tried to make it sound more complicated. Yeah, but it's just a case control study based in a hospital. So that's where a lot of you find patients. Okay, high stability and high repeatability. This is maybe a little bit of like year 12 chem. Yeah, no, right? Okay. High stability, high repeatability. Hands up for A. Hands up for B, hands up for C, hands up for D. Yeah, so it's actually high reliability. So reliability is stability and repeatability, I guess. Validity is talking about internal versus external. So internal validity is, do the results accurately reflect the experiment you did, the people in the experiment? External validity is, can you generalize these results to a wider population, not just the people in the study? Yeah, and so they do not equal each other, because you could have a very biased sample, and so sure, your results are great for this one sample. But if you look at the wider population, if that's not reflective, you can't have the external validity portion. And reliability is kind of just what you learn in year 12 chem, which is stability and reproducibility over time. Okay, cool. Okay, numerical versus categorical stuff. Types of data. Yeah. So I shortened it because I can't be bothered typing this out every time. But yes, SSC is stages of cancer, and body temperature is BT. Okay, cool. All right, let's go through this. So stages of cancer. So stages of cancer, first things first, is it categorical or numerical? Yeah, and so if it's categorical, is it nominal or ordinal? Yeah, and so that means that the order does matter. Like, we don't randomly assign stage 1, 2, 3, 4 cancer. It actually has a meaning which order you're in. All right, body temperature, is it numerical or categorical? And is it continuous or discrete? Yeah. Cool. All right, in a negatively skewed set of data, which of these is true? Yes, the mean is the average, median is the middle number, mode is the most occurring number. Yep, like I see a lot of people drawing the like graph. Yeah. All right, hands up for A, hands up for B, hands up for C, hands up for D. Yep, so it's B. So if you look at the graph, so negatively skewed is where the tail is. This is on the negative side. The mode is higher than median than. Okay, cool. Okay, null hypothesis talk. If the null hypothesis is rejected when it should have been accepted, this is a okay, hands up for A, hands up for B, hands up for C, hands up for D. Okay, so it's A. Okay, guys, 10 more minutes. So a type 1 error is when you reject the null hypothesis when it was true. Type 2 error is that you accept the null hypothesis when it's false. So there's no like particularly like memorable way to memorize this, but I think if you kind of just think about the null hypothesis, if you're rejecting it, that means that you're looking at your data and you're seeing significance where there isn't. And type 2 error is doing the opposite, where you stay with the null hypothesis, which is that there's no change or something like that, and you accept that even though there's significant change otherwise. Yeah. Cool. And sample size too big or too small, that could be a cause of your error, but you can't really infer that from the question. Yeah. Okay, biostatistics. Okay, this is my least favorite part. Because in all honesty, there's not a specific way about it to like understand what all of these tests are, because we kind of just don't have the mathematical basis. We kind of just learn about these tests at an end result. Okay, cool. So 1 sample t-test and 2 sample t-tests. The more common one is 2 samples, where you are comparing 2 sets of numerical data. So a specific kind you might see is paired t-test, where it means that you have the same individuals and you're measuring their data perhaps before and after an intervention. So that's commonly where paired t-tests are used. Chi squared test is when you have 2 categorical variables. Linear regression is that if you have a continuous outcome with multiple or 1 like exposures or explanatory variables. And logistic regression is binary outcome. And confidence interval, you guys, most of you I think will kind of already know what that is. Yeah. But there's also great videos on biostatistics I think they give you. And so I don't want to go into too much depth with that because it's a little bit complicated. Yeah. Okay. So which biostatistics test should I use? You want to compare the mean blood pressure in 2 groups of people who are randomly assigned to 2 different groups in a clinical trial. For this time, your treatment groups include both men and women, and you like to make sure the gender balance of the 2 groups does not confound your result. So what biostatistics test should I use? So I'm going to go through this question with you guys together, because I think it's a bit mean to just make you answer it based on me explaining it once. Okay, so chi-square test, so 2 categorical variables. So we don't actually have a categorical variable because mean blood pressure is not a categorical variable. So it's not that one. Yeah. So t-test. So this is when we are comparing 2 sets of data. We don't have 2 sets of data. Like the 2 groups are not really comparing them. We're trying to just find out the, oh my gosh. T-test is 2 sets of numerical data and we only have 1 set, I think. No, wait. Oh no, you have 2 groups. So you could do a t-test. So you have 2 different groups and you have numerical data. Yep. Linear regression is that you have a continuous outcome variable with 1 or more explanatory variables. Yep, we have a continuous outcome variable. And logistic regression, we do not have a binary outcome. Does that kind of make sense how you use the different tests? It's a bit complicated, but basically just kind of remembering what they each are used for will help you kind of eliminate it when you read the example. Oh no, where did it go? Yeah. Okay, outbreak investigation. Oh, sorry. It was C, but I think it also can be B because it's 2 groups of people with numerical data. Fun? You have 2 different numerical results which you're comparing. So mean blood pressure is a numerical result. And so you've got 2 groups, and so you're comparing them. Yeah. So cool. All right. What is the importance of the epidemiology curve? So 8 A, it helps determine what type of outbreak has occurred. B, it shows whether herd immunity has occurred. C, it helps determine the median incubation period. D, all of the above. So it's A and C. Because you can't actually show whether herd immunity has occurred or not. So herd immunity is when you are checking whether the majority of the population is vaccinated against something. And you can't really tell that from an epi curve. So with an epi curve, you can check whether it's point source or propagative. So point source, you only have one spike, whereas propagative, it'll increasingly get more and more cases, and they'll be in different time periods and with increasing severity usually, so more cases. And you can look at the median incubation period because you can figure out how long it takes for disease to occur. Yeah. Okay. So these are just a couple of definitions. Outbreak investigation isn't that important in your kind of questions. Like I found in general, it's mainly based towards the descriptive stuff, so all that numbers, calculations, kind of things like that. So, but it's important to kind of, they'll make mention of these terms and assume you know what but they won't ever ask you to define it in general. Yeah. So infectivity, capacity to cause infection in hosts, pathogenicity, how able it is to cause disease, and symptoms. Virulence is the severity. So, and then when you're looking at like the different curves and stuff like that, index case is the first case in the population. Primary is the first identified or notified case. Secondary case is those resulting from primary cases. The reproduction number is important because it tells you a lot about a disease. So it's numbers of cases generated by each infected individual. So if you have a really high reproduction number, you're very, very worried about how quickly the disease can spread through a population. Because let's say like, okay, if I have the disease and I only infect one other person, okay, that's pretty manageable. But I cough and this entire lecture theatre is now diseased. That's a really different thing you're dealing with. Yeah? Cool. Oh, I'm nearly out of time. Okay. Oh, how many slides do I have? Oh, I have like 5 slides. I'm doing great. Okay. So infectious and clinical periods. So incubation is the time in between when you're exposed to when you have symptoms. Critical disease is like the actual presenting disease you see. Latent is time from when you are infected until you are infectious. And infectious is when you can spread it to other people. Yeah. Okay, prevention. So primary prevention. So it goes primordial, primary, secondary, and tertiary. You'll actually do like an entire assignment on this next year. So get ready for that. So which of the following is it's actually a really good assignment, guys. But anyway. Okay, so which of the following is an example of primary prevention? Hands up for A, hands up for B, hands up for C, hands up for D. Yeah, so A is a lot of your public health kind of campaigns tend to be more primary. So primary is before you have the disease. Nearly there, guys. So primordial is the determinants of health. So this is big, like policy, structural legislation, trying to change stuff about like education and housing, like all this like big stuff that doesn't. Oh, sorry. What are you gonna say? Because it's not actually affecting the social determinants of health, kind of like that really, really big overview stuff. So it's more targeted before disease onset, but it's not affecting like everyone who experiences like, yeah, so it's not like so if they had a tax on alcohol, that'd be more primordial because you're even taking that away. But primary prevention is it's leaving a lot of the structure in place by trying to do health promotion. Secondary prevention, so screening is always secondary. So that's something to keep in mind. So if you see screening, I saw a couple of you guys vote for that. That is secondary prevention. And tertiary prevention is when you already have the disease. You're trying to stop it from getting worse. Okay, last question. Health promotion strategies should A, target all the diseases with serious consequences. B, should target all diseases with a high prevalence. C, should target disease with a high attributable risk. And D, should only use primary prevention. Hands up for A. Hands up for B. Hands up for C. Hands up for D. Yeah, so it's C. So if you targeted every single disease with a serious consequence, you'd have like 1 million genetic diseases that affect like one person, and that's not effective. Target all disease with a high prevalence. High prevalence doesn't talk about how able we are to actually change the effect if we target it earlier. That doesn't speak about the actual disease. But with a high attributable risk, we know that the exposure is very closely linked to having an adverse outcome, and because of that, it's worth treating. And we shouldn't use only one type of prevention, because why would we have 4 types of prevention if we only use one? Yeah. Okay, cool. That's it from me, guys. Thank you so much for paying attention. Good luck with everything. If you have any questions, I think there's another lecture, so I can't really stay around, but feel free to email me. Yeah, that's my email. Cool, thanks, guys. Yeah, it's okay.
I can see if it works. But yeah, I have a USB here.